This is a maybe hard to read grid, but it really speaks to the complexity of our evaluation at a program level. And now 8 years down the road, we've now benefited by being able to look at agreeability between clinicians and other components. But again, building a valuable evaluation early on, I think, is a critical part of program success. This is, I think, 3-year data that spoke to our pre-post measures. So blue was the before they started and yellow being afterwards. And what's fascinating about this graph is we don't treat eating disorders, and we aren't promoting ourselves as an alcohol treatment center. And lo and behold, we actually are treating successfully the major depression, panic, and anxiety extremely successfully. And because that's what our model of care was to do. So as you'll see later, we targeted this population and we're succeeding at it, and we're very pleased that these were showing up. When one moves to try to show how successful the change was going over time, and again, these are numbers on individuals who received 3 or more visits only. They may have received 5, may have received 6 visits. Most of this care is either a psychiatric consultation, but predominantly meeting a counselor in a primary care setting early in their illness. So one moves before they begin services well above the blue line, which is 1 standard deviation above the normal general population, to actually approaching or acquiring what would be the average individual who is symptom-free. So this was at the functional level using the HUDOS. I won't get into these numbers beyond to say that the last 3 D columns speak to standard deviations of movement. These individuals are not just moving 10%, they're moving 30 to 50% closer or towards the norm. And these are substantial movements in a clinical finding setting when compared to clinical sample versus a normative sample. So these are substantial movements in the targeted areas in which we sought very prevalent disorders. This is on the symptom measure, again, a very broadly used now PHQ-9. We probably have one of the largest databases using PHQ and have presented or published on the quality and success of the DSM in this setting. But again, you're seeing similar things: depression pre, depression post, approaching or actually at normal function as the general population. This is the second study that we participated in. We labeled it TIP, Transition to Primary Care. The idea here was not just consultation and counseling, but management of the serious mentally ill in the primary care setting. It was the first randomized controlled trial. We obtained a grant of $250,000 from the Transition Fund grant. And this was based on a CLIP model of Australia, and the website is available that details quite well the model of care. I won't detail the outcome measures, but what I can say is that we covered as broad as we could things such as family's response before, family's response during treatment, patient response, clinician response. We wanted as broad of an evaluation, and we also included a cost effectiveness measure and worked with two of the few mental health economists through CAMH. And what's interesting about this finding, or this study, first of all, is it was not intended to show difference. This was only to find out if the methodology was acceptable to the patient population. It occurred in London and Thunder Bay. We sought to have about 50 to 60 patients, and I think we succeeded about 45. As is usual with funding, the money arrived late. We had to go from 2 years to 18 months to 12 months of funding. A number of other delays occurred. What's interesting is what we did was as good as what the family doctors did without us. So we contributed to the possible finding because we were not powered enough to show this. But the concerns were how well the family docs, how were they doing? The patient gets discharged from the LPH, they go back to be managed by the family physician. This is only 1 or 2 of the graphs. They did as well as what we did when a nurse and a psychiatrist followed them. So on the one hand, you find quite a bit of success when you are largely powered. We don't know whether this finding will play out if we were to do this, which was our intention, in a multiple site. But again, we have an opportunity now to look at what happened here. What is it about the docs in Thunder Bay that followed these 25 patients that did as well as having me and Jennifer Leto follow this patient back to the family physician? So we have interesting contribution to the scientific literature from Thunder Bay about what's going on here. And we don't know what's going on because we wasn't powered enough, But nonetheless, it's a study that was funded, and a lot of other information about our value came up, but it was through the stories, not through the numbers. Okay? The patients liked having the backup. The family physician said, I wouldn't have taken these patients if you weren't there. Same thing showed up on the number of symptom measures, and basically this was across the board in satisfaction. That even though the care as usual went up and went down, the fact is they didn't change a lot, and they were satisfied with knowing they had a family physician probably back in their pocket. Just a few more slides left. Despite modest support, when we first started, we were kind of a modestly funded, 2 counselors and me on my time through the LPH and St. Joe's. We were able to develop with some successful findings because we, like in Canada, we're slowly moving from pilot to mainstream. But believe me, it's slow. This model is not on wildfire here. It's not something people are motivated to do. Primary care is frontline. It's not necessarily an easy place to work. We feel that why should it succeed and be considered to be advanced is that it's supported by, in the literature quite well, as I've mentioned. And I'd like to think that it's also recognized as the fact that I'm here presenting to you as one way in which the system overall could be evolved. Primary care has been often the orphan non-participant, and I think continues to be. And I think that the opportunity in shared care for us has been a dialogue with individuals that were also starting to do something new and evolve the system. And having that moral support, having colleagues to support, I think was critical. So if you're thinking about it, try to link up with people across the country that are doing like interests. So what advice or what ingredients would I consider for yourselves, for those that have the purse strings here to think about and have these decision-making influences? If you're going to consider this, try to find some degree of your budget that's assigned for evaluation, whether it's 3%, 5%, something that allows some recognized at the start, we want to build something new, we want to also show what works and not works. Certainly try to engage your partners in sharing and even if it's non-funded, for us it was as simple as sharing the rent. That was our shared costs. That they liked having us there. They felt, gee, we're glad to have a psychiatrist at all. Oh yeah, you can use our office as long as it's not more than a couple half days a month. That worked out fine. So creating those relationships. For programs that are starting out, looking for other successful individuals to mentor or coach. But don't compromise creativity. If anything, to take ownership, individual programs, I think, need to have that creativity. I certainly think the presentations today will speak to that. I think I got one more. Sorry. Targeted population. As I mentioned, if we try to treat everybody with mental illness that has every addiction and every personality disorder, that may not work, but certainly if you're going to evaluate, target the population you want to succeed at. Try to make deliverables. I think programs need to be accountable by what they do. I think it's reasonable to have some evaluation measures. It's reasonable to have them accountable by presenting. How did it work? I'd mentioned already about expert advice or modeling, peer support. And I certainly think grant applications, people want to support on as funding becomes available to enhance what one does, to evaluate further what one is doing. And I think in a small way, most of our funding has been less than $25,000 most of the time. So, and I certainly think that assistance with the LHINs could be such as government-wide databases. What impact is your service happening on OHIP billing patterns? There's a variety of questions that we often think we can't ask, but there are individuals that might be able to help generate that, and having maybe some forum in which what other ways can we evaluate our impact can occur.